Welcome to this session on what's new on the IPS. Just to double check, we just switched rooms, so make sure you're at the right talk right now. This is Rob Hausam, and he'll give you some more insights on the IPS the coming 15 minutes. Go ahead.
All right, thank you very much. Thanks everybody for being here this morning. I'm really happy to be able to talk with you about the International Patient Summary and a little bit about what we have in the works for IPS 2.0 and the FHIR IG and some other things. And it's only a little bit of time, and I got maybe probably too many slides, but we'll see if what we can get through, and hopefully have a little time for questions at the end. So this is just a little bit about me. I'm Rob. I go by Rob, and I'm an MD, a family physician. I'm a healthcare informatics consultant. I actually just highlight I've got a new European company as an Estonian e-resident that's actually active over this week. So just mention that. I'm a co-lead on the IPS project and one of the main primary editors of particularly of the FHIR specification. I've also worked on the CDA in the past. And I'm contributing to the new IPSCC group, which we'll talk about in a little bit more, and co-lead on the ISO 27269 revision, which we also talk about, and active on a number of other projects, including what Peter Williams is talking about next door, Snowmelt on Fire. I'm also involved in that group too. But anyway, happy to talk about the IPS today. So we'll start with a bit about what the IPS is. Many of you, if you've been to IPS presentations before, I'm sure have seen some variation of this slide, and you probably saw it yesterday in Maximilian's talk if you were there, and I'm not sure what Casey's going to be talking about in his talk on Friday, but what slides he's got, but you'll see some variations of this. But IPS is a standardized set of basic clinical data. It's intended to include the most important health and care-related facts. It's a summarized version of the patient's clinical data, and the idea is to provide professionals with the essential information that they need when they need to care for a patient. That's not normally one of their patients in their jurisdiction. They need this. We can provide this information to them so that they can provide better care. That's really the ultimate goal. The IPS is intended to be, what we call, some principles: minimal and non-exhaustive, a set of basic clinical data. It's intended to be typically specially agnostic. It's not necessarily focused on one clinical area, but it has broad coverage. It certainly can include content from relevant clinical areas, particularly if a patient has special needs. Those definitely can be included, but it's not focused on any particular discipline normally. It's also condition independent, but again, it can certainly provide the details for any important clinical conditions that a patient has. And then the idea is to make it readily usable by clinicians particularly for unscheduled care and cross-border. And we'll talk more about what cross-border is here in just a second. In fact, so the idea is again to provide data that's essential for continuity of care. If I come over here to to Amsterdam and I need health care, it'd be great for me to be able to bring my IPS and show to a local provider here and have them have the data about me. And that's one of our ultimate goals, to get to that point. And so that gets into the cross-border idea, but it's really important when we talk about cross-border with IPS to, we talk about the national borders as sort of kind of the high level, the prototype, or we're traveling internationally, we're doing all these things, but really there's lots of other borders that we encounter in health. And many of those may be provincial or state and regional, across many, Canada and the U.S. both have different health systems in different places, and one of the most important borders to cross might be across the street to the other local health system in your town. So IPS can be used in all those scenarios, across organizations and any other kind of border that you can imagine where there's some barrier to having immediate access to your health data. So that's what that's one of the main problems we're trying to help solve. And so I'll talk just a couple of slides here about IPS in both as a FHIR document and also in the other in the CDA version. I got in the next slide. We also have that as well. But as a FHIR document, the IPS is the document itself, at least, is a bundle. It uses the composition resource to organize the patient summary, and it's intended to have both machine-readable content and also human-renderable content as a typical FHIR clinical document. And there's a new FHIR clinical document IG that's being developed and hopefully soon published as well, which will be try to be in accord with that. We're kind of doing parallel development here. And you'll see on the slide, it's probably too small to really read back where you are, but number of the sections that we have, we've got some header information, basically essentially document information about the patient and, the author, attester, custodian, that sort of thing, similar to what you would see in a CDA document. Then there's required sections for allergies and intolerances, medications, and problems. All conformant IPS documents, should include something about those. Even if you don't have any, we want you to say something about it. So maybe we'll talk about that here in a moment as well. But then there's other, recommended and optional sections. And within the recommended, there's immunizations and other things that are very important clinically, but we don't always require them to be sent. But so with the composition resource, we have basically those elements that describe, the document itself. And then that links back, though, to all of the various individual resources that carry the data in the document bundle. So that's the basic structure in FHIR. And we also have it, as I said, in the CDA version. We did the CDA work first, and then we did FHIR. And we've got at least a general commitment to try to keep those aligned. As long as there's continuing interest in the CDA version, we're still working on it. There's actually been, you'll see in a moment, there's a recent ballot of that CDA version as well. And so as long as there's interest, we'll try to keep those both in play. So if you want a broader introduction to the IPS, this is a great place to go, the internationalpatientsummary.net website that we've put together to kind of provide a one-stop shop for all the things about IPS, and you'll find a lot of different things there. I won't try to drill into that, but you can get to it with the QR code there or the link. And also, if you haven't already seen it, there's one of my colleague, John DeMore, put together a 5-minute video intro to IPS, which is actually very interesting and useful. If you haven't looked at it, you might want to do that. So there's the link to that there. And that can give you some additional background. So next thing I want to do is talk a little bit about sort of our process for putting IPS together and how we work. We've done something that I think is a bit pioneering as far as working across multiple standard development organizations in a very collaborative way to get to where we are with the IPS now. And this is a pretty busy slide. I'll just try to point out maybe a few things. But we started with a lot of the work in Europe with CEN, the European Standards Agency, with basically it was the 17269 standard, and then moved from CEN into ISO as a 27269, and you see that here, and we'll talk about that more later. But along with that sort of ISO at the top, basically providing what we call a data set standard, kind of describing what the IPS is, but it's a lot more of a logical, description model, whatever. It's not an implementable standard itself. But then for implementation, we've got the two HL7 specifications I mentioned, the CDA and the FHIR. And then IHE also works with us, and we have a couple of IHE profiles, one for the general IPS that covers both the CDA and the FHIR, and then a sharing of IPS, which is specific to the FHIR. So all these organizations work together, including SNOMED in the middle here, which provides us with terminology for the IPS as a special IPS, what we call free set, or the IPS terminology, which actually provides a sub-ontology hierarchy of terms that SNOMED makes available for use in the IPS. So all these organizations working together. And another part of that is the Joint Initiative Council, which again is a cross SDO organization trying to promote our collaboration. And we have just recently formed the IPS Coordination Committee, IPSCC, which is now under the auspices of JIC. And it basically picks up on the work that we did previously more informally with what we called the IPS cross-SDO collaboration. Now it's kind of pulled into the the GIC mix. And there's a white paper you might want to look at about the future of IPS as a global public good. It's worthwhile reading about where we are and where we want to go with this. So this is a slide that gives a little more detail on what the IPSCC is about. Just trying to ensure coordination across all these organizations, and basically to make sure that we have something coherent and moving forward. And I'll go ahead and skip through this. You can read it more at your leisure if you want to go back to that. But it's important maybe to note the organizations that are particularly involved at the present time: SEN, HL7 International, IG International, ISO, and SNOMED are the 5 active SDOs that contribute to this. And again, as I mentioned, it kind of picks up and carries on the original work of the cross-SDO collaboration group that we had. So then the next thing, going back to that top box in the diagram, ISO 27269, which is termed the International Patient Summary Standard. It basically describes the data set, like I said, and we're making some progress and some updates there too. So in fact, we just concluded a meeting in London last week on this, and basically what we have is the second edition of 27269, which has added some new sections for both alerts and patient story, and have done a lot of clarifications and various editorial cleanup. And we've submitted it for what ISO calls an FDIS ballot, which is only for editorial changes only. That was submitted at the end of March, and we've made a few other updates with the editors since then, and we've now got the final submission out since the meeting last week. And the ballot should be opening by the end of this month, and then there's a ballot period of 8 weeks, and then we should have a publication of the updated version. So we're expecting it probably in early September. And this is intended to be a solid base for future updates, the 3rd edition, and whatever we have beyond that. And then there's another kind of exciting thing. We've set up what's called a maintenance agency in order to be able to have more timely updates to the IPS specification, starting with, again, at the ISO level at the top. Normally they have like a 5-year cycle of updates, but for IPS, we want to be much more dynamic than that. So the maintenance agency has the ability to basically put out updates on, almost instantly, really, pretty close. And so it can bypass some of the usual things that kind of slow the process down. We've had several meetings, including the 6th one we had last week, and getting the timely updates. And the updates will be published as basically supplemental guidance to the standard, kind of basically errata, and they'll be public available. The standard itself you have to pay for to get access, but we're starting to move in. Freely available standards is kind of the thing, and so we're so this is a move in that direction. But all the updates that we publish from the maintenance agency will then be incorporated in future versions of the standard. So those are some of the things on the SDO front, basically. This slide just talks a little more about the value of IPS. It's providing an international format, in the universal realm, a baseline with, typically recommending at least regional agnostic terminologies. We don't really lock terminology down very, very tightly in IPS because we know there's a need for a lot of flexibility with various, local implementations. So we try to be as flexible as we can on all of that. But the idea is we're empowering patient and provider mediated exchange, both paradigms, leveraging the global investments in FHIR, and allow for domestic adaptation, and getting support, which you'll see in some of the few next slides from major technology vendors that we're starting to see, and building on the documented benefits we've seen about interoperability and things we've been hearing about so far already this week. So some upcoming plans. We're going to tend to publish the FHIR IG version 2 very soon. I was hoping maybe I could say we have it published. We don't quite have it yet, but it's pretty close. So our 1.1 version was published back in 2022, November, but we should have it out officially within the next couple of months, I would say, at least, maybe even a little sooner. We've got some continuing support for tooling and reference implementations, and advancing various techniques for exchanging the IPS documents using QR codes and smart health links and things like that, and again coordinating the activity amongst the SDOs. Okay. I think I've got about 5 minutes, and that's about right, I think. So recent IPS ballots that I mentioned, we have the FHIR. We balloted both of them in September 2024, both the FHIR and CDA. And so if you want to look at those materials, they're out there, HL7. And a summary of our status, we're probably about 85%. I'm guessing that's about where we are now. It's a little hard to measure exactly, but on the ballot reconciliation. So we are really pretty close. We did some work on obligations in FHIR and incorporating that into our IPS specifications, and that's kind of a huge benefit, I think, for the implementers, because it makes things much more clear about what you do need to do and what's the role of, basically of, the various producers and consumers, essentially. What do they actually have to do? And so we've tried to really clarify that. We had a lot of feedback on that, and we've tried to make some good progress in that. And we're seeing a lot major EHR vendors releasing this functionality. So I see some folks in the room that are doing that, and got multiple countries contributing, and you can see the current progress in the CI build, which will basically is very close to becoming the final updated 2.0 version if you want to look at it now. So this, a lot of detail here really, but major updates that we have done in the 2.0 spec. We allow now sending empty sections using the empty recent element. We previously did not allow that, and you had to create a resource basically to say, I don't have any information. We decided that probably wasn't really the best approach, so we're using the set composition section empty reason now, and I think people are happier with that. We've added these new sections that came from the ISO, and we've added them in the FHIR specification. And we've got updates to the summary operation. We've made clarifications to that and fixed some of the in-parameter types which really weren't quite right. We reworked our observation profiles for simpler use and better validation. We've made some, our terminology simpler, easier to look at, and we've just about got fixed the narrative linking issues that we ran into. And again, the must support transition to obligations is kind of the biggest thing. So, all right. So that's the slide here. You might want to, it's a little too much detail to really be able to see, but you can actually go in and look. And basically the thing is that these boxes here you see, which basically say that the obligations for the, basically the producer, you shall populate if known. For many, that's not. There are some other variations that we have, but that's one of the common ones that we see. And then for the consumer, you must be able to handle, and you must be able to display. And that's kind of the typical pattern that we have for most of the elements. All right, so last few slides, just kind of some more things that we're doing as the whole community. We've got IPS viewers, and we've got sample data, and we'd like to get more samples for anything that you have. And validator tools, and we've got the reference implementation and reference server based on the happy work that James Agnew's done and has presented on before. In the last few years, you can find those presentations, and we've got some demonstration projects like from Washington State using smart health links, and some very good work there. We've got the IPS passport application that Graham Grieve has put together just fairly recently. And I think I'm about out of time, but that's something worth checking out if you haven't already seen that. Sort of a way to do a patient created IPS and do some special things that that Graham wanted to sort of emphasize, and he's got a nice application for that. And again, this smart health links, you can look into more details on that. So some other significant developments quickly. Canada has launched IPS in 2 provinces, New Brunswick and Alberta. Brazil has published an IPS plan, and ePatient Dave, was at HIMSS and back in 2024 and was definitely promoting this. And then we've got again, I mentioned the IPS implementations and vendor support. This is a list of the in-production ones that we're aware of, and we've got, I won't read all these, but you can see at the bottom, though, I will, just mention as a big one is Epic, and we're really happy to see that, and we're seeing some others coming on board as well. And in development, we have a number of others, including Meditech, another large one, and various other ones in Canada and other places. And so we're really, really happy to see this getting to this point. And we've had some very high-profile events. I think Carl mentioned just a minute ago in the keynote, and I'll have a talk on it later. I'm not sure when it is, but about the HAJ, the work used the IPS in the HAJ. And you can read a little more about that there. And also in Latin America, the LACPAS Connectathon has done some great things with IPS, and we're really excited about that. So I'll leave you with kind of a thought here on really the last main slide. And this quote is attributed to Margaret Mead. I'm not certain you can absolutely verify that, but it's a great quote, I think, is never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And we feel that that's basically what the IPS community has been doing and is continuing to do, starting back in 2016 when we kicked this off in Oslo, talking about the principles and moving on up to this year. So that's where we are, and hopefully you might have a minute or two for questions. I don't know. You can contact me here if you want, and we got Q&A and feedback, and that's it.
Thank you, Robert, on updating us on the latest updates about IPS. Are there any questions? We don't have a lot of time, so maybe just one or two questions.
Thank you very much, Rob.
Yeah.
I'm wondering if you can comment on pseudo-IPS implementation guides, things that are IPS inspired but not IPS conformant. And then on the flip side of that, another one of expanding scope would be using IPS documents for purposes beyond the initial scope.
Okay, so yeah, that's a great question, Elliot. I think I would just say that we want to be as inclusive as possible and allowing for as broad a use as possible of this, but still maybe trying to figure out how to hold true to the kind of the spirit of what IPS is about, and the fact that it's a summary. It doesn't want to become the entire dump of all your patient data, all your lab results for the last, 20 years or things like that. We want to keep it as a summary of the relevant clinical, data that's would be most important for a subsequent care encounter. So within that range, and and trying not to make it completely all one specialty or limited to one kind of resource, or kind of set some boundaries around that. But they're fairly open. We allow for people to add additional things to IPS. If you have additional information that we haven't profiled, you're welcome to include that in your IPS instances. And we want, I think, if you have a use case that maybe really kind of goes beyond the general spirit of the IPS as a FHIR document, then we definitely encourage using the IPS profiles individually in another document that you might create or whatever, and have as much compatibility as possible. So I don't know if that answers the question, but yeah.
Hi, Bas van Heuvel Philips.
Yeah.
In Europe, IPS is getting traction.
Yeah.
So we get IPS from many different sources. And in the end, there's only one IPS. So will the spec provide guidance how to harmonize an IPS when the data comes from multiple sources? And if not, where do you think such guidance might be defined or produced?
That's a great question, Bas. It's something that we've definitely anticipated, and we deliberately left out of the specification at this point, because we want basically to not kind of prejudge or unnecessarily constrain implementation efforts and ideas. I mean, we need to gain experience with implementations, and particularly when right now we don't have, our problem is we don't have enough use of IPS. When we get to the point where we have too much IPS, or maybe not, a lot of IPS being used, then we're really gonna, we're gonna be able to need to figure out how to exactly how to handle those things, but we didn't feel like we could dictate in the specification yet. So we expect to have additional guidance documents and implementation experience, and that will begin to cover those things. And as we gain clarity, we'll be able to add those things to the specification going forward.